Should we begin?
Yes, ma'am, go ahead.
Yeah. Good afternoon, everyone. I welcome you all to the Foxy ICOG JOGI Research Methodology and Journal Club. So this is our second episode, and we have planned this episode on the first Tuesday of every month. And we have eminent speakers this time. Let me introduce you to the conveners of this program. Nilima, can you play the slides of the conveners? Our convener is Dr. A.G. Radhika. She is a senior consultant in OBGY, University College of Medical Sciences and GTB Hospital, Delhi. She has special expertise in evidence-based healthcare guideline development. She holds important positions like National Coordinator for Clinical Research, FOXY. She is a recipient of various awards, expert reviewer. Thank you, ma'am. And the next convener is Dr. Sujata Darvi, ma'am. She is the editor-in-chief of JOGI. She is a consultant obstetrician and gynecologist at Bhatia Hospital, honorary clinical associate at Vadia Hospital and Jagjeevan Ram Hospital. She is the secretary of MOGS, managing council of MOGS since several years, and madam has several publications and several awards to her credits. I now request both the conveners to introduce our Foxy President, Secretary General, ICOG Chair. May I request Sujata Darvi ma'am and Dr. A.G. Radhika ma'am to introduce?
Is Dr. Sujata there? So, very good evening to all. Very warm welcome to yet another session of Foxy, JOGI, ICOG Journal Club and research activities, clinical research. So, Pradnya has invited me to introduce the office bearers. I think it's also important to introduce Pradnya herself. She is an assistant professor in the Department of Obs and Gynae at LT, MMC and GH. Secretary and Manager, Journal of Obs and Gynae Society, Gynae of India, meaning the JOGI Journal. MUHS recognized PG and undergraduate teacher, member of Youth Council of Bogs, and has many articles in index journals to her credit. So thank you, Pradnya. And now we go over to the office bearers. So we are extremely proud to be supported and blessed by Dr. Sunita Tendulwarkar, the extremely dynamic president. And I think she is one person who really truly does not require an introduction. And we are very happy to be, supported by her. We have Dr. Parag Binewale. He is the Senior Consultant Obs and Gynae at Pune. He is a PG teacher and unit head at Kamla Nehru Hospital, chairperson of ICOG 2025, president of...
Don't waste time.
Yeah, so welcome to you, Dr. Parag, and we would also invite you to, share a few words of wisdom with us, please.
Thank you. Good afternoon. I bring greetings from ICOG and my apologies because I'm traveling from Mumbai to Pune. My signal is shaky. But I must appreciate the efforts put in by Editor-in-Chief of JOGI, Dr. Sujata Dalvi, and our own Dr. A.J. Radhika, who is the governing council member for this particular activity. Of course, ably led by the very, very enthusiastic journal team. I'm certainly looking forward to the two sessions today because we have none other than Shailesh Puntambekar, who has a lot of firsts to his credit and who will be the faculty today. So on behalf of ICOG, welcome one and all, and let's have a good learning session. Thank you very much.
Yeah, thank you so much, Dr. Parag. And we have Dr. Suvarna Khadilkar. She is the professor and head of department and consultant endocrinologist and gynecologist at Bombay Hospital. She is the Secretary General of FOXY 2025. And as you can see, the entire screen is filled with her accolades and credits. So then we have Dr. Ashok. He is a director professor in the Department of Obs and Gynae at Atal Bihari Vajpayee Institute of Medical Sciences and RML Hospital, Delhi. And he is a vice chairperson 2025, secretary ICOG 21-22, and he is going to be the chairperson next year. Then we have Dr. Sarita Bhalerao. She is a consultant obstetrician gynecologist at Bhatia Saifi Reliance HNH and Breach Candy hospitals. She is the secretary of ICOG. We all know her, and immediate past year of AICC RCOG West, and a lot of accolades to her credit. So, with the huge support and encouragement from the ICOG and the Foxy and Yogi office, we are here with this session today. So, over to you, Pradnya, to introduce the speaker. We do not have chairperson for the next session, so it is Pradnya
Yes.
Supe, and over to you, Pradnya Chengde, please.
Yeah. I think
Thank you.
Sujata madam has just joined
Yes,
us. We
Sujata
welcome,
madam has just joined us.
Okay.
we
So,
welcome our editor-in-chief, Dr.
yes.
Sujata Darvi ma'am, to please share a few words with us.
Yeah, okay. So I would like to welcome one and all for the second ICOG Jogi workshop that we are having it today. And I would like to express my gratitude to our Foxy President, Dr. Sunita Tandulwadkar, ICOG Chairperson, Dr. Parag Biniwale, Vice Chair, Dr. Ashok Kumar, and of course ICOG Secretary, Dr. Sarita, and Foxy Secretary General, I'm sorry, Dr. Suvarna Khadilkar. I would also like to express my gratitude to my co-convener, Dr. A.G. Radhika, who's already introduced you to the topic that we are going to discuss. And of course, today's coordinator, Dr. Pradnya Chengede, who would be briefing us on the rest of the program. And I would like you, Dr. Pradnya Supe, to go ahead with the today's talk. Then I won't take much of your time, and Pradnya Supe can start off with the talk.
So can we have Dr. Pradnya Supe's slide, please? So, Dr. Pradnya Supe, she's a secretary and manager of JOGI. She is a consultant at Chembur Surya Hospital, and she is ex-assistant professor in Department of OBGY at Sion Hospital. Welcome, Dr. Pradnya, and she is going to speak on reference management for researchers, Menley, Zotero, and EndNote. Welcome, Dr. Pradnya.
Yes. Thank you, Pradnya. And I think I will start. So today I'm going to give a demonstration on how we go around using reference managers. So yes, just a minute. Let me just share my entire screen. So
So while Pradnya is sharing her screen, I would like to also just give a brief introduction of what these reference managers are basically for. So are you ready, Pradnya?
yes, ma'am. Yes, ma'am.
Yeah,
So
this is I think you are sharing your slides. It is not your
ma'am, just two
screen.
slides and I'll go
Yeah.
to the demonstration. Yes. So reference managers for researchers is something many of us, even though we are into research, we are into publications, is not something we really utilize to the greatest extent. So they are softwares which help to collect, simplify citation, organization, and collaboration. They help us to collect and store, organize references, insert citations in the appropriate place in the body of the manuscript, help us to generate a list of references in an appropriate bibliographic style, and help to integrate with word processors. So which reference manager should one use? So sorry, I'm not able to move this properly. Yes. So the commonest reference managers which are easily available, the commonest being Mendeley, Zotero, and EndNote. So what I'm going to do is I'm going to actually give a demonstration on how we can go about using a Mendeley's reference manager. So whenever we type a Mendeley reference manager in our Google search or any Chrome, this is the website that we go to. As we can see, it has three main things that we need to be aware of. One of them being a Mendeley reference manager, which we can download and use it on our desktop. The other thing being Mendeley site, which I will be coming to. And the third thing is the web importer. So let us first see how a Mendeley's reference manager looks like once you download it and install it in your computer. This is the Mendeley's reference manager, and this is how your home page of Mendeley's reference manager will look like. As we can see, this is how we can add references. Now here we can add references by either importing files from a computer, import files, select from folders from your computer, or transfer a reference library into Mendeley. We can also add these references manually by actually typing the article or the number of the article. Then here we have all recently added references which we've added. I will come to how we can easily add references into this Mendeley's reference manager. Recently read and my publications, which allows you to add your own publications to this reference library. And simultaneously, we can also create collections where particular topic based or maybe an article related articles can be put in one collection. So this is the Mendeley reference manager. Next,
Pradnya,
Yes.
would you like to also show the menu which is there on the top? So the edit, because it also helps you to
Yes.
put
Yes.
your this thing in a certain format. So you could use the Vancouver style or the
Yes.
AMA
Ma'am,
style.
I
So
will be coming to that. Ma'am, you're talking about this, right?
yeah, so you if you just show the audience just for familiarity, you can export your references, you can import the references.
Yes,
Or
you
would you
can
like to
export.
cover that? Yeah.
Ma'am,
What?
so you
Yeah,
can,
yeah. Fine.
yes, you can export all these references to other reference managers as well. Ma'am, I'll cover that citation when I take the site manager,
Sure.
what you're talking about. So this is how your Mendeley reference manager looks like. Now coming back to what other options we have as far as Mendeley's reference manager is concerned, then we come to the Mendeley site. Now Mendeley site is which we can incorporate along with our Microsoft Word, and that helps us what Madam was talking about to really utilize the adding of citations into a Word document. Is my screen completely visible?
Yes, it is. We can see.
Yes. So Mendeley site. Now, how do we add these Mendeley site to our Word document? So basically, once you have downloaded the Mendeley site, all we have to do is go on to our home tab and click on add-ins, where we get a number of options about what add-ins we can add to our Word document, and we can add in the Mendeley site. This is how your Mendeley site looks like. References, citation settings, and we have other tools as well, which is insert the entire bibliography and more options as well. So here now you can see a few references which are already seen in my window. Now for example, keeping my cursor in the document where I want to add this particular reference, I just click and I insert this citation. And I can go to the citation setting. I can change the citation styles. There are various citation styles which are available. The Vancouver, American Medical Association, American Psychological Association. I can change the citation language and I get a preview of the citation style that I have chosen such. If I add more citations, if I go here and here I go again here, I add one more citation. So now I have two citations which I have added from the Mendeley site into my document. I can again change the, and so I get this entire, so I can add the citations here. The third part of this Mendeley reference manager is the web importer that I'm talking about. Now, web importer is nothing but a small extension which we can see on our Google Chrome window. Here you can see the small Mendeley icon. This is the Mendeley web importer. Next to it is the Zotero web importer. So let us see how we can directly add. So here I'm going to my Mendeley library. When I go to the Mendeley library, I can directly search for articles. For example, if I am typing obesity and PCOS and I search in my Mendeley library, these are the articles that I come across. Similarly, when I am and here I just click on this article and I just go to the Mendeley web importer and press it. And this article will be automatically added to my Mendeley library. Just to show how it happens, say I am going on this article and I'm just clicking on, it is showing me all the references which are present on this page. I click on this. I'm going in the collection that I want to add it to, that is PCOS, which I can see, and I'm just adding. And but if I go back to my Mendeley reference manager and I go to the PCOS collection, I will be able to see this article in my Mendeley reference manager. So this is, if I want to do the same to an article in PubMed Central or any other web page, I can similarly go to the Mendeley web importer, click on this. It will show me all the articles, not just the main article, but even all the references which are present on the page. And I can click on either one of them and just add them to my Mendeley reference manager. Moving on to the second reference manager which we have, that is Zotero.
So, Pradnya, there is one query from the audience. She
Yes,
says,
ma'am.
can you tell me the step for Mendeley site? So, it is very simple. I think this query has been.
Ma'am,
can
I
find
didn't
this,
understand the query. What is the query?
how to
For
add
Mendeley
in
site.
the.
Yes,
Yeah, yeah.
I will do it. Yes.
So,
So for
yeah, I'm
Mendeley
sure you'd be
site,
showing for the other one
yes,
also.
yes.
Yeah.
So for Mendeley site, we need to go to Mendeley site. We need to click on this particular icon which tells us Mendeley site and we can get it. The only thing is for Mendeley site, you need a Microsoft account. And with this Microsoft account, you log in Elsevier. And then once you have downloaded this Mendeley site through your Microsoft account, you can just go to your Word, go to your home, and Mendeley site add-in will directly be visible on your Word, Microsoft Word. I hope I have clarified this doubt. So the second reference manager which we are talking about today is Zotero. Zotero also has a plugin, but I think there is some problem, so I was not really able to use it. But even in Zotero, we can even insert research articles in the similar way. It also has another tab for my publications, duplicate items, and you can also both these Mendeley as well as Zotero also have a notebook section where you can write your thoughts. There is also, you can add references and annotations and info regarding any particular article that you want to write about. So going back to my PPT, so let us just see in detail each of these. Mendeley is owned by Elsevier. It's a desktop plus web-based platform. Mendeley Reference Manager can also be used as an online manager. We have its PDF annotations, collaboration through group, like I showed, is at a citation plugin for Word, and it also has a cloud storage of 2 GB. Zotero is developed by the Corporation for Digital Scholarship. It's open source and free, has browser integration, tagging and notes, and again supports many citation styles. It also has 300 MB of free cloud storage. EndNote is again developed by Clarivate. This is a paid software as compared to Zotero and Mendeley, which are comparatively free. It is more useful when academic licenses are offered and is often provided by institutions. So this is just a differentiation between all the three softwares, namely EndNote, Mendeley, and Zotero. They are compatible with mostly all operating systems, can be used as a desktop as well as an online system, and all of them come with unlimited local storage and some amount of online storage as well. So which one should you use when? Mendeley is more user-friendly. Zotero is free, has browser integration. And EndNote is for advanced citation and forming and best used for when you have large academic projects. So just to conclude, all these tools have strength. You need to choose based on your research needs and preferences and try and see what works best for you.
So in answer, yeah, thank you very much, Pradnya. I think that was a very, very informative talk. So I just
Thank you,
wanted
ma'am.
to respond to the query raised by Dr. Rohini, which one to download while you were showing the slide. And so what I
Yes.
would say is the user experience. The EndNote is a paid one. Zotero and Mendeley are free, and the user interface and the friendliness of Mendeley is really very good. And another aspect that I would like to also talk about regarding Zotero as well as all the three actually, there is something called MS Word plugin. So, Pradnya, when you showed that Word document, can we just get back to that, please? Can you
Yes,
just,
ma'am. Yes, ma'am.
since
I
we
can do.
still have some time, we can, I think,
Yes,
just
ma'am.
demonstrate that also,
Ma'am, I'll just show you. Give me
the
just a
Word
minute.
document.
Yes, ma'am.
We want the Word document, please.
Yes, ma'am. I'm going. I'm going. Give me
Yeah, yeah,
just 1 second. Yes, ma'am.
certainly.
Here I'm on the.
Yeah,
Please,
so if you
this.
go to references,
Yes.
yeah, click on that. So there is insert citation. Can you,
Yes, ma'am.
yeah, there is one. So so when you have a plugin, if you have a Mendeley plugin or a Zotero plugin, so the citation, insert citation, when you open that, so here it says add a new source. There it would be selected. If you have Mendeley as the source, it will show up on the screen there. So what Pradnya showed as the Mendeley site. So Mendeley site requires an active connection to the internet. So if it is already downloaded in your desktop or in your laptop and you wish to work offline, so then what Pradnya just now demonstrated through the references, you could work offline on these reference managers, and these you can choose the kind of format for the bibliography and the references, and this bibliography will get developed on its own. So now you demonstrated the use of the two references that you used here. Can you just show how the bibliography develops? Can you just go down, Pradnya? At the end of the
Yes, ma'am.
document, you can just
Yes, ma'am.
paste the bibliography so that people can see how easy it is. So
Just a minute.
since you used the Mendeley site, you can use
Yes.
Mendeley
Yes, yes, ma'am.
site for that. Yeah.
See,
That's it.
I mean, yes.
So easy it is. So
Yes.
if there is a change in the, when you are editing this and you move your sentences up and down, or you
Yes.
delete a reference, everything is hyperlinked here. It is interconnected. So it reflects very easily in the bibliography. You don't need to go on looking at your bibliography and change things. So
So,
that
ma'am,
is
I
the
want to
utility of,
one point which I missed is,
yeah,
see, whenever you are downloading the Mendeley reference manager, the site, Mendeley site, using a same email ID will make more sense because then your Mendeley library will be connected to the Mendeley site. So I already had the Mendeley reference manager. For some reason, it is not taking up my other
yeah,
Outlook account. So I'm not able to really show that. But I think if you are a new beginner, you're just downloading, please download even your Mendeley reference manager with an Outlook account. So the Mendeley site can directly read into the Mendeley reference library and help you put in references, site
yeah.
references in your document.
You need to sign in, and you can
Yes, you
also
need to
use an
sign in.
alternate sign in. So there are all options available, like Pradnya is saying. So it's a
Yes.
good idea to try it out on your own. But these are very useful tools, and we would recommend for everybody to have a first-hand experience and use these also.
Yes. So, ma'am,
So
I'll
thank
stop.
you. Yeah, yeah. So any questions from the audience? So which is better for MacBook?
Is better for MacBook. See, all three of them do have MacBook OS versions as well. Mendeley definitely does, even Zotero does, even EndNote does. So, like I said, depending on which reference manager you find more appropriate. For example, Mendeley is most user friendly. So it depends, whatever you find. But all of them have Mac OS versions. Ma'am, please correct me if I'm wrong. But
No,
I
they
think
certainly
yes,
have. They certainly
yes,
have.
all of
Then
them have.
all can be used. Yeah.
Yes.
So thank you very much, Pradnya.
Yeah, thank
Pradnya
you,
Sube.
madam.
Yeah, yeah. So over to you now, Pradnya Chengle, please.
Yes, ma'am. So we are now going to begin with a very, eminent speaker, Dr. Shailesh Puntambekar, sir. And for this session, I would like to invite the chairpersons. Our chairpersons are Dr. Anaita Chauhan. Madam is an honorary consultant at Saifi and Elizabeth Hospital. She is a former professor and unit head at St. GS Medical College and KM Hospital. She has more than 30 years postgraduate teacher experience and has been the past president of MOGS. Welcome, madam. Our next expert is Dr. Fessy Lewis. Sir is a senior consultant and associate professor. He is in charge of the MCH course, Department of Reproductive Medicine and Surgery at Amrita Institute of Medical Sciences, Cochin, Kerala. He is been the Foxy Vice President and has several publications, awards, and he's also the editor of the KFOG journal and the website. He's received Foxy Korean, Kamini Rao, Yuva Orator, and several awards. Welcome, sir. Our next expert is Dr. Jyoti Banglawala. Madam is a chairperson, Ethics and Medical Legal Committee of Foxy. She has 28 years experience in the field of OBGY, is a medical legal advisor, and is presently the Vice President of the Indore Obstetrics and Gynecologic Society, Treasurer IOGS, and she is the coordinator for Medical Legal Workshop. Again, she's a recipient of several awards and has been invited as a faculty in various national and international conferences. So I now request all the experts to introduce our next speaker, who is Dr. Shailesh Puntambekar, sir. Can I request the experts to introduce the speaker? I think.
Pradnya Shala and
Yes, ma'am. Please, please
okay.
go ahead.
Thank you, Parag sir and Sarita Pradnya, both Pradnya for inviting me. And this is actually a very interesting topic, learning curve of total laparoscopic hysterectomy for a resident in a high volume resident training setup. It's an actually interesting topic. This is the Journal of OB/GYN in India in August 2021 by Dr. Shailesh Puntambekar. He is the laparoscopic cancer surgeon and robotic cancer surgeon, and presently he is the medical director of Galaxy Care Multispecialty Hospital. And he considered as an expert in pelvic anatomy, and he patented the technique of radical hysterectomy, Pune technique of laparoscopic radical hysterectomy. He conducted various he conducted India's first successful laparoscopic assisted uterine transplant. A baby girl was delivered on 18th of October in 2018 at Galaxy Care Multispecialty Hospital. He is the only Indian to be the board of member of AAGL and faculty member of AAGL Oncology Committee, and later as International Secretary and Treasurer for AAGL. He is the operating faculty at IRCAD and various other international organizations and their conferences. He has been the largest series published of the transthoracic esophagectomy and endoscopic or robotic, and known for performing the most difficult laparoscopic and endoscopic surgeries, thyroid, renal, upper GI, and colorectal, and pioneer in the laparoscopic anterior posterior extension of cervical, uterine, ovarian, and colorectal cancer. He was awarded the Foundation Signature Award from AAGL for his new concept of anterior parametrium, which explained the spread of cervical cancer in 2020. He awarded the AAGL Golden Telescope Award, and he has received the same award for AAGL 4 times in the past for the excellent work. And this IRCAD thing, actually now we in India is having only one center of the IRCAD, and that is in the Indore. And I also looking forward to see Puntambekar sir operating one day in Indore. I welcome you, Puntambekar sir, for your talk.
Yeah. Can we request Dr. Shailesh Puntambekar, sir, to share his screen and begin his talk?
Hello, good evening, everyone. Dr. Madhvi this side. Sir will be joining in 5 minutes, madam.
Okay.
Okay.
Just 5 minutes. Thank you.
Okay. So if there are any questions on the reference manager, we can take up those questions. Radhika ma'am, would you like to answer?
Is there any written question in the chat box? We can see.
Yeah, so Dr. Pradnya, Dr. Radhika. Yeah. So if you have any questions, you can post in the chat box so we can read. Please unmute Dr. A.G. Radhika ma'am. So if any points are left out, Nilima?
Yeah, can you hear me now, Pradnya?
Ma'am,
Yes,
if
madam.
any points are remaining in the presentation, can we discuss this? Because Dr. Puntambekar sir will take 5 minutes to log in. So if there are any points that you would like to discuss, we can have them.
No, I think reference managers are today the most important part of any clinical research. So I think it is important for people to realize the advantages other than what has been already presented so well by Pradnya. There was that collection section there that Pradnya showed in Zotero. I think it was in Mendeley. So for each research, when you go enter into a library, these reference managers are actually like libraries. So when you add your references there, they actually catalog your references and arrange them in a way that you can very easily access them. That is number one. Number two, many of them also function as the web search managers. They are also good for searching for the literature. So, for instance, Mendeley is one of them. So you can do a web search for your articles and add them directly into the Mendeley reference manager in the format that you want, right? And many times what happens is these the replication of web search strategy, especially when you're writing a PhD, for example, or a systematic review, when your references run into thousands, it's so easy to look at these to replicate the process of searching, which is so very important in these major research processes. So these, I think, are grossly underrated by many people. So I think it is high time for people to start using them. So one is about the collection, and below that is the authors. So if you're looking for a research article by the name of an author, that is also a possibility in these reference managers. So there are a lot of other facilities and activities which can be undertaken. So it is important for people to familiarize themselves with these. EndNote also is a good reference manager, but it is paid. No, Pradnya, you are muted, please.
Yeah, so I think people have asked for a dedicated hands-on session in the future. If we can have
we would
it,
be very happy.
Workshops, I think we can actually, take a topic, find the literature and add it to the reference. I think people will benefit from it. I think in the AICOG, Delhi can take it up and they hold a big step workshop there so that the students
We
can
can
learn.
do that, and no, I think Pradnya, if it is a demand of the audience, we can do that in these sessions also. No?
Yes.
I think there are people who are not able to come to AICOG. Here, people can attend online, and they can practice it. So we can think both the options. Think of both the options.
Yes, I think Dr. Fessy Lewis sir has also joined us. Welcome, sir. Sir, please unmute yourself.
Hello, ma'am.
Yes, sir has joined.
Sir has taking time to complete the case. So till that time, I'll present the paper, and then for the quoting, sir will be come as a conclusion point of view. Sir will
Okay,
come
so you will present the paper and then sir will come to answer the question.
Yes.
Sujata ma'am, is it okay? Or you want to take the second speaker? Sujata ma'am, please unmute yourself.
Yeah, I think we go ahead with whatever it is because it's not going to happen. So let it be. Let her present, and otherwise we can go to the second speaker and then
Is
we
the
can
second speaker ready?
अच्छा जी धन्यवाद.
just see if second speaker is ready. We can give. Otherwise, we go ahead with the way it is.
Yeah. Just a
If
second. Is
second
Dr.
speaker is ready, we can go that, no?
Yes, we can. We can get the second speaker, and we wait for the
Yeah.
first
Dr.
one.
Padma Rekhe Girje, is she available now? Has she logged in? Dr. Pradnya Supe, can you call her and just check? Yeah, she's just entered. I think she has entered. We'll ask her to because I think everybody wants to.
Just ask her if she is ready.
Yeah, she's just joined it. Dr. Padma Rekhe Girje. Hello, ma'am. Nilima, please unmute.
Yeah.
Ma'am, are you ready with your talk? Because
I'm ready.
Sir will take some time. So can you present your talk first?
Okay, just hold on. Can I share my...
Yeah, you can share the screen.
Yeah.
Can you see my screen?
Yes.
Yes. Last screen. Okay.
Sorry. Yeah. You can see now?
Yes.
Yeah.
Make it screen.
Share slideshow, please.
Yeah, I'm doing it. Because I was not ready thinking that
Yeah.
Dr. Puntambekar will be presenting. Yeah. So, shall I start?
Yes.
Yeah. First of all, thanks to all of you for having me here today and asking me to address this review article which has been published in the Journal of Human Reproductive Sciences last year, that is on anti-Mullerian hormone and fertility treatment decisions in polycystic ovary syndrome, which is a narrative review. So basically, we know that the synopsis is, we know that AMH is a robust marker of ovarian reserve and ovarian response in IVF. However, for a period of time, it's been understood that probably its role extends beyond its diagnostic abilities, and we wanted to explore and see what is the evidence available. So we know that AMH is raised in PCOS, and the recent evidence-based guidelines recommend.
Others, please mute.
Shall I continue?
Yes.
Yeah. So recent evidence-based guidelines, international evidence-based guidelines recommend use of AMH as an alternative to polycystic ovarian morphology on TVS, not on its own as a diagnostic criteria, but with along with other criteria of oligoovulation and hyperandrogenism. It can be incorporated in addition to, instead of PCOM. But does its role go beyond its diagnostic abilities? And this is something we need to understand because there is an ever-increasing understanding of ovarian physiology, and also there is improved assay methodology as far as AMH is concerned. So apart from predicting expected poor or hyper responders in IVF, which we are all very conversant with, current evidence does suggest that AMH may assist in decision-making while choosing appropriate management options in infertile women with PCOS. So we first looked at the methods and materials were literature search. This was done along the lines of what we would do for a systematic review, but we restricted our search to only PubMed, Medline, and Google Scholar until August 2023, using the terms PCOS, anti-Mullerian hormone, AMH, and clinical utility of AMH. RCTs and observational studies published in English language alone were included. Case series, case reports, and non-English language publications were excluded. Cross-references were manually searched, and Zotero was used for reference management.
So the figure shows the Prisma flow of search strategy. In all, 800 articles were identified. 6 were duplicates. So 794 were screened for title and abstract. Subsequently, 690 were excluded after reviewing the title and abstract. 106 potentially relevant articles were identified for full text review, and 34 additional were obtained through cross references. So 46 articles from this were excluded after review as being non-relevant, and 94 full text articles were referenced for this review. Now, the review looks at the primary role of AMH as in being IVF. So we all know that AMH predicts hyper response in IVF with the highest specificity and sensitivity compared to any other ovarian reserve marker. And AMH above 3.5 nanogram per ml, according to DSL assay, that is the first gen assay, predicts excessive response with 88% sensitivity and 70% specificity. With such prior knowledge, what we can achieve is improve the safety of treatment, that is by reducing the starting dose of gonadotrophins, using antagonist protocol, and also utilizing GnRH agonist as a trigger instead of HCG alone or in combination with all this. And in addition, we can do segmentation of treatment as well. Beyond this, does AMH predict success in IVF? So there is some evidence that actually AMH values can be associated with prediction of pregnancy rate. In an unselected population, not restricting to PCOS, we know that live birth rate increases with increasing AMH as per evidence from a meta-analysis. In addition to this, there is a weak positive link between AMH and cumulative live birth rate, because many of the times we may not be transferring embryos in a fresh cycle. So it's important to understand the cumulative live birth rate. So a systematic review subsequently performed and an additional meta-analysis confirms this. So we can utilize this information in young women undergoing IVF for a positive pre-treatment counseling. The link between AMH and implantation is weaker in women with PCOS, according to a systematic review. So compared to those who have reasonably good AMH, whether in those with PCOS, we can actually say they have a higher chance of pregnancy. Yes, there appears to be a link, positive link, but it is weaker than what is noted in the unselected population. Various factors such as severity of PCOS, associated metabolic and endocrine alterations, and variable secretions of AMH from the follicles may all influence this link. Very high AMH levels may be associated with low live birth rate compared to those with PCOS, but a lower level compared to very high levels. What is this high level is variably defined as 8.7 or 10.2 nanogram per ml in 2 different cohort studies. This could be because of altered oocyte quality or endometrial aberrations in such women. However, the large data from SART registry, that is the American IVF registry, including more than 2,700 women with PCOS, showed no decline in live birth rate per ET, and they concluded that an apparent decline in live birth rate following fresh cycles is actually due to segmentation of IVF and cancellation of fresh transfers and shifting over to FET. So there doesn't appear to be any negative impact of AMH, high AMH in women with PCOS, irrespective of the levels. Pre-treatment counseling regarding segmentation might be necessary in those with very high levels regarding segmentation of treatment and FET instead of fresh transfers. What about women with ovulation, undergoing ovulation induction? I thought this was a very important part of the entire review, because there is increasing evidence which shows that women with AMH greater than 7.7 nanogram per ml have a reduced ovulation either with clomiphene citrate or letrozole, but not necessarily with gonadotropin. So this is with for oral ovulation induction. This is an important evidence coming from multiple studies showing that a level more than 7.7 nanogram per ml is associated with reduced ovulation induction. So incorporating this into treatment planning can avoid protracted treatment cycles without ovulation and the frustration patients may experience thereof. What about in the context of IUI? Does AMH have any prognostic value? A retrospective study in more than 700 women suggested that ovarian response is less likely to clomiphene citrate or letrozole with AMH greater than 9.3 nanogram per ml, which is very much similar to what is seen in the scenario of ovulation induction. And this was anovulatory cycles were more common with clomiphene citrate compared to letrozole. So the authors suggested that maybe we should consider gonadotropins as first-line therapy in such women or consider higher doses of clomiphene citrate and letrozole. Another pilot study with gonadotropin suggested that the response is ideal, good in those with PCOS, but AMH less than 4.7 nanogram per ml. However, in those above 10.2 nanogram per ml, the response is poor. Obviously, because we do not dare to go beyond certain dose of gonadotropins. In the scenario of IUI, the stimulation is much milder compared to IUI to maintain the, compared to IVF to maintain the safety margin. However, there is absolutely no study at present which looks at AMH values and live birth rate in IUI in women with PCOS. And the other area is a subset of women with PCOS may benefit from IVM. It may prove to be a safer option, that is in vitro maturation, rather than stimulating the ovaries and experiencing severe or life-threatening OHSs. So what we know now is AMH of 1.63 nanogram per ml is likely to yield 5 mature oocytes. And in those with AMH greater than 8.5 nanogram per ml, taking them through IVM, we can achieve a pregnancy rate comparable to IVF. Does AMH actually predict the occurrence of metabolic abnormalities in women with PCOS? The current evidence is limited, conflicting, and does not support a prognostic role for AMH in women with PCOS to predict an increased risk of metabolic syndrome. So we should not be using it to predict metabolic syndrome, and we should go towards more conventional markers of metabolic syndrome to diagnose it. However, interestingly, there is a small set of studies which do show that AMH is an independent marker of preterm delivery in women with PCOS. Higher the AMH, higher the chances of preterm delivery. There doesn't appear to be any known mechanism which predicts this occurrence. And there are more laboratory studies, ongoing laboratory studies to look at the possible mechanisms of association between high AMH and preterm delivery. While we are utilizing AMH to prognosticate outcomes in women with PCOS, we also need to understand there are certain factors, extraneous factors, which influence the AMH levels. One of them is age itself. We know that AMH reduces with age. So older women with PCOS AMH may not be very predictive of diagnosis of PCOS. However, in those populations where nomograms for AMH already exist, even if the AMH level is within the nomogram 5th to 95th centile, those above the 75th centile for age is likely to be predictor of PCOS. Again, those women with PCOS have undergone laparoscopic ovarian drilling. The AMH level decreases, but it should be considered as normalization of ovarian reserve rather than an abnormal decline in ovarian reserve. Metformin, we know that prolonged use of metformin does lead to reduction of AMH. And again, this should be considered along the similar lines of LOD as normalization rather than abnormal decline. Somebody who has been on oral contraceptives recently, combined oral contraceptives recently for more than 2 to 3 cycles, or is concurrently on COCP, we should not be using PCOS. I mean, we should not be using AMH to assess ovarian reserve, because it does lead to a decline. Then vitamin D, the effect is inconclusive, but there is concern that lack of reduced vitamin D may be adversely affecting AMH values, and there might be decline in the AMH value with low vitamin D levels. Certain genital infections, most commonly genital tuberculosis, all this data has come from our country, does show that presence of genital tuberculosis can lead to a decline in AMH and may mask the diagnosis of PCOS in some women. Obesity, again, declines AMH levels. However, the levels invariably remain above the PCOS, non-PCOS level. Another factor we need to bear in mind is the type of assays we are using for assessment of AMH. Gen 1 assay, that is DSL, and the current Alexis and other automated platforms are more or less very similar compared to the Gen 2 assay, which was the most unstable assay available for AMH. So whenever we are interpreting the results of any of the studies, it is important to look at what assay were used in those studies to decide on how much importance need to be attached to the results of those studies. So this review has looked at the role of AMH beyond a diagnostic marker. So this review acknowledges the primary role of AMH is in estimation of ovarian reserve, and recently published international evidence-based guidelines for diagnosis and management of PCOS considers this as one of the diagnostic criteria for PCOS. But the review primarily looks at the prognostic role of AMH in PCOS management. What it suggests is incorporating AMH into our assessment module may prevent prolonged futile treatment, and thus avoid lot of emotional and financial and loss of time for these young couples, young women affected with PCOS. High AMH for ovulation induction indicates that we may need to use higher starting dose of clomiphene citrate or letrozole, or more likelihood of need for gonadotrophins. In IUI, very high AMH does indicate reduced response to stimulating strategies, particularly those involving gonadotrophins. This is more likely to be due to the softer protocols we must use in IUI rather than any other specific reason behind it. In IVF, the most important role is it improves the safety of treatment by starting with lower doses of gonadotrophins, by incorporating antagonist protocol, and also by selective use of GnRH agonist when we anticipate that there is a very high risk of OHSS. In those who have experienced very severe OHSS in the past, or life-threatening OHSS, or where it is predicted to be such kind of a course following ovarian stimulation, AMH is a good predictor of what we can achieve with in vitro maturation. And interestingly, it is an independent predictor of increased risk of preterm delivery in women with PCOS. So to conclude, beyond its diagnostic role, we actually should be using this to in routine. It should not be, current evidence does not support as an additional diagnostic marker in those with established diagnosis of PCOS or its evaluation routinely before first line therapy. But if it is there and somebody has very high AMH level and not responding to maybe 5 milligrams of letrozole or 100 milligrams of clomiphene citrate per day, then we should consider moving on to gonadotropin instead of using protracted courses of stimulation. However, in addition, it may play an important role and assist in clinical decision making in those resistant to or fail to conceive with oral ovulogens. And laboratory issues related to different AMH assays have a limiting factor, and a good understanding of these is important. And this review provides a clear section on the factors which may influence AMH values in various clinical scenarios. Thank you.
May I request Dr. Fessy Lewis, sir, to comment on this?
I think Dr. Padma, that was a very good article. I think even the smaller aspects of how the different metformin, GnRH, LOD, everything affecting the MH has been elaborated. Right now, we have, before going to that, we have one question. I think you must have seen it by Dr. Rohini, telling that what is there any mention about the evidence that the cycle dependence of the AMH is been mentioned in that study?
No, I haven't, we have not included anything about cycle dependence, because I think more or less it's a robust marker and there is evidence. I mean, we have not mentioned that here because this study is about treatment decision making. So we did not include that. I think there is enough evidence to say that there is not much of intercycle variability with AMH, or compared to any other marker, it exhibits the least amount of intercycle variability.
Okay. Thank you so much. May I now request Dr. Anaita Chauhan ma'am to introduce our next speaker, Dr. Shailesh Puntambekar, sir. Nilima, can you flash the CV? Nilima, can we have Dr. Shailesh Puntambekar, sir, CV?
Yes, yes.
Can you stop sharing, Dr. Padma?
Sorry. Yeah, sorry.
Disconnected in between. Hello. I got disconnected in. Okay.
Just a minute, ma'am, I'm sharing.
Yeah.
Dr. Padma. Who's there? Pradnya?
Yes, sir. Yes, sir.
Yes, sir.
I'll just forget the CV. I'll just start my presentation. Why do you want?
Actually, sir,
Everybody knows about me. Chalo.
Sir,
No, it's okay.
Everyone.
Yeah, I think you can start, doctor.
Yeah, madam, I think we should start.
I think you should start.
Okay,
Yeah.
yeah. Just forget. Madam, just
Yes,
forget the
yes.
introduction. Everybody
Yes,
knows.
we'll start with Dr. Shailesh. Pradnya, start.
Yeah, just stop sharing.
Okay, okay.
Okay, we'll start. Okay.
Yeah.
Thank you.
Yes, sir.
Thank you,
Okay,
doctor.
I will
Thank you,
share
sir.
now. Yeah.
Yes, sir.
So, play कुठे करायचं? हे खाली घे फक्त. This you have to take it down. Play. Okay, are you seeing the slides?
Yes, sir.
Yeah, so good evening, everybody. At the outset, thank you for adjusting my talk. I just finished my surgery and then I joined in. So this is, I think, the second time we are participating in this JOGI thing. We won the award for the one of the first presentations that we shared, and this is the second one. So this is, ours is a high volume center. We have almost 6 gynec fellowships every year. And the background was that we started our journey of laparoscopy in 2002. So we decided that whether it is possible to duplicate the step. The entire idea was whether we can duplicate and transfer the technology. And with this idea, we had this that we devised the steps in 1, 2, 3, 4 manner, and then decided whether this can be duplicated by the newer residents or anybody who wants to learn from the bottom of the heart. So this was basically to assess the safety profile and overall outcomes, focusing not only on we never focused on the time, we just focused on the steps of the surgery, whether they are duplicable, and we focused on the complication, and we focused on the numbers that are needed to train a particular resident. Then when we can leave him alone under supervision, of course, but not over that area. So this is the learning curve of total laparoscopic hysterectomy for the residents. So to evaluate the resident learning curve, demography and comparative analysis. This was the retrospective. Prospective data was collected, but the analysis was retrospective, and this was an observational study. So 801 total laparoscopic hysterectomy patients were operated by the residents. Before that, we have also a paper of 1200 laparoscopic hysterectomy, also in JOGI. TLH patients performed by the residents were evaluated with the learning curve, duplication of the steps, the results of intraoperative and postoperative complications. And the surgeries were absolutely assigned as per the inclusion criteria. So whatever were the inclusion criteria for total laparoscopic hysterectomy, the patients were enrolled according to that. The fellowship program is the MUHS, Maharashtra University, that is which is the health university controlling all medical colleges of Maharashtra. So this is a fellowship period for 1 year. The residents initially performed 10 simple cases under supervision and another 10 cases which were performed completely independently based on the learning curve. And this is what we thought we will do. 801 women were enrolled. Average age was 45 years. The pathology, you can see every kind of pathology from adenomyosis to uterine prolapse to chronic pelvic disease, myoma, everything was included. Previous surgeries were also included. Medical risk, diabetes, hypertension, and age less than 70. We did not include age more than 70 in this study because since it was to be done by a resident, we wanted to be sure. We also did not include more than 30 BMI, again, because this is the learning curve. You have to be very careful that they don't lose their confidence in this entire period. So 194 where adenomyosis, fibroid 280, which form the bulk of the reasons for total laparoscopic hysterectomy, and rest are were very, very low. Risk reduction surgery, that is the BRCA1 and BRCA2 positive, these patients were also included in the study because these patients want their ovaries as well as the uteruses out. So you can see the commonest among them. This was the previous surgery which was done. LSCS was the commonest, which was 64% of our patient had a cesarean scar. Rest of the surgeries were not that many. Size of the uterus, you can see the uterine size was between 6 to 12 weeks in maximum number of patients, and 16 weeks was the maximum size which was encountered. Again, this was basically to understand whether they understand the steps, and therefore it was from the simple to difficult cases. The patients were preoperatively prepared as we prepare for every patient. Bowel preparation was done. Single dose of intravenous antibiotic was given. Patients were admitted on the day of surgery and were discharged on the next day. Anesthesia use was a combination of spinal and general anesthesia. We started using this because spinal anesthesia causes sympathetic blockade, as a result of which the bowel doesn't come into the pelvis, and therefore it is very, very helpful, and a general anesthesia also. This was the position that we use. This is what we have published way back, keeping a bolster at the level of the anterior superior iliac spine. It divides the pelvis into two parts because the line of mesentery goes from the left to right, and automatically the small bowel goes into the right lumbar region and the right iliac fossa, then obviating the need of very steep Trendelenburg position. And this is what we published. Only 30 degrees of Trendelenburg was needed. These were the camera ports which were used. 5 ports were used. In our institute, we use a myoma screw for manipulation. We do not use any kind of manipulator, because my teaching was, because these residents, when they go outside, they don't have a very big team, and it is always better to manipulate the uterus with with yourself rather than depending on somebody else. So primary trocar was put under Visiport. Uterine manipulation was by tenaculum or myoma screw. Use of these three energy sources was common. We started teaching them initially with ligashore, and then later on, as they became more and more better with their hand movements, they were allowed to use bipolar cautery and scissors, which is the basic thing, because if all energy sources fail, then at least they can be done. Uterine morcellation was performed. Of course, we did not use monopolar current because these were the initial days. So this is the procedure. I don't think we should go through this procedure, because this is a very simple procedure that we did. This is how they use ligashore. You can see the tubes being taken out. This is performed by one of my residents. And you can see that with two hands and ipsilateral hands, they could perform this procedure quite well. The steps were very easy. We made them sure that these steps are repeated at every point of time. Even in the patients who required BSO, we first told them to do a hysterectomy and then later on take out the bilateral salpings, and bilateral oophorectomy was done later. So this is the procedure that we did. And you can see the key step was to go and open between the two layers of broad ligament. And this was the key step that we taught, because we told them that the vessels are always between the two layers, and carry the posterior cut right up to the apex of the uterosacral. So apex of the uterosacral is the most important landmark, because the ureter and the nerves, they lie at the base of the uterosacral. So acute anteversion will give you the entire area. This pushes the ureter away, and then you can see the bladder dissection was from the anterior fold. This is what we did, and we showed them how to do this. So these are the various steps. You can see small baby steps. These kept on getting repeated with every resident. Fat belongs to the bladder, so push below the fat and remain anterior to the cervico-vesical fascia was our teaching. You can see, just do the blunt dissection and then don't use any energy source, and plain simple ligashore. This was the first step that we did to teach them, and they really learned it very well. You can see this is the fat. They went below the fat, and this is how you can see they were trained. Just remain below the fat, just remain below the fat, and you can see the cervico-vesical fascia coming in over there. So this was the step for bladder dissection. And then once we did it for bladder dissection, once it was complete, then of course what we did was to go and take how the vessels should be taken. So you take the left hand at the apex of the uterosacral. So look at this. The left hand is at the apex of the uterosacral. Do not go lateral to the apex of the uterosacral. Take the clamps as you take in open surgery. Slide your clamp paracervically. So take your clamp, side your clamp, and it will come. Your left hand is always at the apex of the uterosacral, preventing you from going below the apex of the uterosacral. This is how we avoided injury. Simple steps. I'm sure all of you do the same steps, but these were the steps that we designed, and come what may, we never allowed them to change the steps. So this is how we can see they went and they just took this. Once they had taken this, they were allowed to use a little bit of harmony to take the uterine pedicle, lateralize the uterine pedicle, and then you remain only on the medial side of the, once you have taken the clamp, do not go lateral to the cut edge of the uterine was our teaching. Go up to the apex of the uterosacral. Apex of the uterosacral remained as one of the most visual signs of your total laparoscopic hysterectomy. And we did a colpotomy posterolaterally. Always posterolaterally, because there is nothing which is there. So all the colpotomies were done at the level of the posterolateral. And because there was a traction, irrespective of elongated cervix, when you give the traction, the cervix always comes at the level of the apex of the uterosacral, you can see. And then we did the circumcision of the cervix, thus leading to a complete intrafacial hysterectomy. So this is how you can see we have always remained at the apex, and has been my teaching for a very long time. Do not go lateral to the uterosacral, maintains the integrity of the entire pelvic floor as well as prevents any damage. And then of course you do the circumcision of the cervix. So this is how we taught them. And then oophorectomy, I'm not going to show you. And this is the total laparoscopic hysterectomy. For bladder dissection, we didn't allow them to use any energy source, but made them use scissors. And then these scissors were more important. These side of cases were only given after 15 or 16 type of cases, patients that they were operated. And with the scissors, they were told, follow the rules. Fat belongs to the bladder, go below the fat and just go below the fat. And then you can see this resident is performing it only with bipolar and scissors. So we also allowed them to use bipolar and scissors at a later date. And this is how we train them for doing this. So this is the colpotomy. Colpotomy closure was also taught to them. Surgical detail, the uniformity of the technique, and repetitiveness, because even if you are not doing the surgery, looking at the same other residents or other consultant doing the same, irrespective. So always whenever my residents come back after 10 years, they say you have not changed the technique, because we feel that any surgery should be taught in a very army fashion, 1, 2, 3, 4, 1, 2, 3, 4. The resident needed to perform an average of 23 cases to complete a learning curve. And this is what we got. This is the blood loss learning curve for the residents. You can see the duration of the stay was only 1 day in 384 patients and 2 days for 321 patients. This was more so when the patients were out of station of Pune for emotional purposes and not for any medical reasons. Bladder injury, we had 3 patients of bladder injury. The maximum injuries that we had were about 12, and the bowel injury was 3. We had, so 1.5% of the complication. This is a Clavin-Dindo classification that we have used, but none we had stage 4 or type 4 Clavin-Dindo classification. So you can see none in 4A, 4B, and 5. So none of these complications were in that, and none of the patients had, we didn't have any mortality. Average complication rate decreased considerably as the numbers increase, but the numbers have to be very, very careful. They should be at least doing 2 to 3 surgeries in a month. So if you look at 23 surgeries were needed, so that doesn't mean that we do 10 surgeries in 1 month and another 13 in the end of the year. That doesn't happen. We saw to it that everybody gets at least 2 to 3 surgeries every month, so that they can get this. And they assisted the same number of surgeries. 6 residents were there. So at least 18 surgeries they were seeing by the residents themselves, besides the number of surgeries that were done by our consultants, which we have 6 of them together. Surgical time was 91 minutes to about 120 minutes. Time reduction was directly proportional to the repetitiveness. This is the relationship. As the numbers of the patients, as their experience increased, the time went down, though the time was never an important factor in our analysis. This is the oral intake. You can see all this. Follow-up residents who had passed out showed that all of them were now doing. The most important thing was that their training did not end here. We followed them up. Since 2011, we are having MUHS fellowships for this, and we also have FNB in minimal access surgery. And I have been a postgraduate teacher for 15 years with DNB surgical oncology under me. So last almost 30 years I've been teaching, and we followed up. We always call our residents to find out whether they are doing mainly obstetrics or gynec. 90% of them are now doing gynecological procedures. The present generation is prepared to accept laparoscopy. What we realized was training the people was more and more easy as the years passed by. So residents who came to us in 2010 and 11, they had a little bit of, there was a mental block whether I'll be able to perform. They had never put a port in their life. But now people come with a complete energized mind that they want to do these procedures, and that actually decreases the learning curve because they're ready to learn. Their hands are better. Hand and eye coordination is 200 times better than what we started in this thing. The change in attitude was very high. And high volume centers, just to make an important point, if you go through the AHL recent paper, which is given in 2024 in United States. A high volume center is considered to be a center with 120 hysterectomies a year. That means 10 hysterectomies per month is considered as a high volume center. We are surely doing more than that. We are doing so. All of us are probably doing more than that. So we should consider ourselves as a high volume center. We do not publish our volumes, and that is the reason we don't have this kind of data. So high volume center have a potential to bring out the best from the resident. Reasons are standardization of the procedure, using the same steps repeatedly, and volumes of the patient. So it is not only standardization of the procedure that will help you. The patients as well, the residents as well as the consultants have to have volumes to do these repetitive surgeries continuously, and uniform intraoperative and postoperative protocols, large sample size. This is the most important thing. The only drawback of this study is that this is a retrospective analysis. Now we are doing a prospective study for all this. We did it for retroperitoneal dissection, and we are also doing it for cadaveric dissection. We have conducted 10 cadaveric courses with 20 people at one time, and hands-on training courses, 20 of them with 20 people at one time. And we are analyzing the data, whether they are able to repeat the steps. And I have so many success stories that they are able to do retroperitoneal dissection. Finally, as a teacher, what is your aim? Your aim is not to show your talent. The aim is to make sure that your residents can rise to that level, because when you become 60 plus, the idea is to sit back and look at your resident surgery and be happy that you have trained them very, very well. So thank you very much. Madam, thank you. This is the conclusion. Learning curve of TLH was found to be 23 cases, and dedicated teaching staff, uniform surgical protocols, and high volume centers contribute to the safety of TLH. I acknowledge the entire staff of Galaxy, including the nurses and all my consultants, and of course the patients who participated in the study in this. Thank you very much.
Thank you, sir, for that elaborating about the study. I think the technique which you had emphasized again, that I think that highlight the way in which TLH can be done, and without having the fear of about ureteric injury, and with less complication. Over to Anita, madam. Dr. Jyoti also is there.
Yeah, Anaita ma'am and Jyoti ma'am, can we have your comments, please? Dr. Sujata ma'am, even you can add.
No. Whatever points that he said, that is the best way to avoid any ureteric injury. At the same time, even a bladder injury, and whatever position that he showed, that it gives you a little bit elevated Trendelenburg's position, so that the intestines don't come away. So these are all the practical points, and I'm sure this is all because he has a very vast experience in TLH. Is something which most of the gynecologists would always want to do it, and they would want to do it in such a way that it causes no complications. So that was a very good practical point from your side, doctor.
Thank you, madam. Thank you, Sujata, madam. Thank you very much. But I would again stress the same thing, madam, that it is just not about the technique. I keep on repeating this at every conference, that your volumes are also equally important. So suppose I take leave for 2 months and I don't come, my speed definitely goes down. So, your hands have to work continuously, and that should be the endeavor. At times, we don't invest so much in our this thing. We want to have a price tag specifically, but because ours is a training center, sometimes we do these surgeries at a very, very minimal cost, because at least the idea is that this is our investment to teach, so that India has some averagely good surgeons. That should be the basic idea, and volume should always be one of the factors to train the people. You should always focus on your volumes. Only then you get better.
Yeah, that is true. In laparoscopy, the more hands move, the better you are. It is that way. You may have an experience, but it has to move every day or maybe once or twice a week,
Yes,
then only it works out better.
Yes. And madam, we do conduct, Dr. Facey Lewis also knows about it. So every 3 months, ours is the only institute in the world where we allow consultants above the age of 40 to come and operate on our live patients. We are having this in month of May. We never advertise We have not put it on any website. This is our 20th course. So all of you are welcome to learn the retroperitoneal dissection on live patients. And this is a very, very intense course of 4 days, 30 to 35 radical hysterectomies we do in 4 days and allowed to do 2 radicals under my supervision. So this is one of the things which helps you to do this. Nowhere in the world you will be allowed to operate on live patients. That is the thing.
Yeah, that is true. Thank you, doctor, so much for being so
Thank you.
considerate.
Thank you, sir. Thank you, sir.
So there are compliments pouring your way, very encouraging study. The technique should be replicated at other centers. And you have been labeled as a teacher's teacher, sir.
No,
And sir, there's a question on the technique for oophorectomy. So can you comment on that?
Yes, we actually do a lot of, because ours is a cancer center, Dr. Pradnya, we
Yes.
do a lot of BRCA positive patients. We get a lot of, nowadays people are very, very conscious if somebody is having breast cancer. So we normally do not encourage a hysterectomy at that point of time, but bilateral oophorectomy is always done. So we tell our residents to pick up the ovary, take it towards God. Always take the tube and ovary towards the god and then take flushed with the entire ovary. You take that. Because if you keep the ovary down, all the structures in the body should be cut facing. So everything should be taken towards God, that is towards the anterior abdominal wall. And then you should cut that so that there is no, because ureter or vessels will not be picked up by this and therefore they will never be damaged. So this is a simple technique to do it.
So thank you so much, sir, for
Thank you,
sparing
madam.
your
Thank you.
valuable time.
Thank you. We are coming out with one more paper, madam. I think we have submitted that. This is our will be, because this is repeatedly we are submitting at AAGL journal and JOGI. JOGI journal we are doing. So we are now submitting our 500 patients of endometrial cancer with P53 gene and ICG. So I think this will be the largest study coming from India. We'll have this. Thank you very much for having me. It's always a pleasure. Sorry to keep you waiting for the first
No,
talk.
no, no, that was, but it was worth a wait. I must tell you that. And I'm sure those who have logged in, I think they'll go home with a good message and they will be able to implement it when they're operating on the patients. I'm quite sure.
Thank you. Thank you, sir. Thank you, madam. Thank you.
Thank you. Yes.
Thank you. So, ma'am, should we?
Yes, we can wind up. Yes, Pradna.
Yeah. Madam, would you like to present the vote of thanks?
Maybe you only give vote of thanks, Pradna. I've said
Yes,
enough.
yes. Okay, so we would like to thank our Foxy President, Dr. Sunita Tandulwadkar, ma'am, our Secretary General, Dr. Suvarna Khadilkar, ma'am, Foxy Chair, Dr. Parag Biniwale, sir, Vice Chair, Dr. Ashok Kumar, Secretary ICOG, Dr. Sarita Bhalerao, of course, the two conveners of this program, Dr. Sujata Darvi, who is the Editor-in-Chief of JOGI, and Dr. A.G. Radhika, all the chairpersons, Dr. Anayata Chauhan, ma'am, Dr. Tessie Lewis, Dr. Jyoti Banglowala, the speakers, Dr. Pradnya Supe, Dr. Shailesh Puntambekar, and Dr. Padma Rekha Jirge for, and all the listeners for, sparing your valuable time and attending this program. So we'll come up with more and more interesting programs, and you can look up at the Foxy and the ICOG Jogi websites for the further programs. So thank you so much, and
My sincere thanks to Dr. Pradnya Chengade for being a coordinator of today's program and handling program so well.
yeah, thank you so much, ma'am.
Thank you. Thank you.
Thank you, everybody.
Thank you.